Hello everyone, this is Reshma Kinney and this is the video where you'll be learning certain basic elements required to understand the pathogenesis of cirrhosis. In this video, we'll be discussing the microanatomy, the function and something about portocaval anastomosis, which will help you understand what happens in cirrhosis and its complications. So moving on, the first thing you have to know is that liver has dual blood supply. First is from the portal vein, which provides 60% of the blood supply to the liver. It is nutrient rich because it is formed by joining of the superior mesenteric vein as splenic vein, and these two drain the intestine. So the nutrients absorbed by the intestine travel through the venous system and they reach the liver through the portal vein. And this constitutes 60% of the blood supply of the liver. The remaining 40% of the blood supply comes from the branch of the hepatic artery, which is rich in oxygen. So these two enter the liver at the porta hepatis. Along with them is this is the common hepatic dust, which is exiting the liver. So these three structures, they divide and then they enter into the liver and place themselves at the corner of what is called as hepatic lobules. Now hepatic lobules are structures formed by the entry of the Glisson's capsule, which is a capsule of the liver, into the substance of the liver, and within the substance the capsule divides the liver into three-dimensional hexagonal structures. Okay, this is in 3 dimensions. Usually when we see a picture of a liver, we see it in 2 dimensions, but actually a hepatic lobule is a 3-dimensional structures, and these 3 structures which I talked about, they place themselves at the corner of the hepatic lobules. So the blood comes from here and then the blood pours into the hepatic lobules from all these places, and in the center we have the central veins. Now each of the central vein of from different hepatic lobules, they join together and finally drain into the hepatic vein, which finally drains into the inferior vena cava. So if you want a simpler representation, a liver is something like a bunch of grapes. Each of these grapes is a hepatic lobule and the stem of the grape is the central vein. So all the central veins join together to form the hepatic vein, and in the corners we have the portal triads. Portal triads are 3 things which we saw the branches of, that is portal vein, hepatic artery and the bile duct. So within the hepatic lobules, the main component of the liver, that is the hepatocytes, have arranged themselves into hepatocyte plates. Okay, they are like plates. This is actually like a brick wall, and each of these plates may be either 1 or 2 or 3 cell thick. And between these plates we have what is called as the sinusoids, where the blood is poured into. Okay, so here I have shown it. So here we have the hepatic artery, the portal vein. They are pouring their blood into the in between 2 hepatocyte plate. This is one hepatocyte plate and this is the other, and they pouring the blood into the structures called as sinusoids. Now here I have shown you what the sinusoids are like. So we have this one hepatocyte plate and this one hepatocyte plate. In between them we have the sinusoids, and within the sinusoids, these hepatocytes are projecting their microvilli. Okay. Now why do they do this? Is because there is going to be an exchange of material between the substances within the sinusoids and between the hepatocyte. That is, the hepatocytes will pick up the substances which are in the sinusoidal blood, that is substances like glucose, amino acids, lipids, many other things that the liver will metabolize or store, and also in return release substances which it has produced like albumin, globulin and coagulation factors. So it is obvious that the kind of blood that enters here is different from the kind of blood that exits here. And for this difference in the blood to take place, this area is very important. That is the place where the exchange happens. Now in this place we have the microvilli and a space which we call as space of Dis or space of Disse. And in this space of Disse exists this particular cell which is of very importance, highly important cell, that is called cells of Ito. Normally in us they store vitamin A. But in conditions whenever the liver shows inflammation for a long time, that is chronically inflamed liver, that can happen because of many reasons, we'll see in the next video. So when the liver is chronically damaged and inflamed, the cells of Ito, they convert themselves into hepatocyte stellate cell. We will see this again, hepatocyte stellate cell, and they begin to lay down collagen in the space of Dis. So once that happens, the connection between the hepatocyte and the sinusoids is cut off. And because of this, the quality of the blood which is there at the central vein will be very similar to the quality of blood which was poured into the hepatic lobule, because the exchange has not taken place. Okay, so virtually the hepatocytes are bypassed completely. Okay, so imagine a liver where the blood is traveling in the hepatic lobules but no exchange has taken place. Okay, so the liver has been bypassed, and this we call it as portosystemic shunt. Okay, porto is for portal, systemic is for central vein. Okay, systemic shunt. Okay, shunt because there is a bypassing of the hepatocytes completely. So this concept is very, very important for you to understand why, in spite of there being a healthy liver tissue, still there will be manifestation of liver cell failure in the patient. So the next thing you need to know is something called as portocaval anastomosis. Okay, the portal vein, it drains, we know, the intestine, area of intestine, okay, and also parts of the esophagus and the stomach. And there are 3 places where even the inferior vena cava directly drains the blood. So these areas are called as portocaval anastomotic sites. So the first one is at the abdominal wall, okay, around the umbilicus. The next one is at the lower end of esophagus, and the third one is at the rectum. There are 2 more, but these are the 3 places where it is clinically significant. Now, in cirrhosis, the vessels of the liver, they get damaged. We'll see why. They are not damaged, they are kind of distorted, because of which it becomes very difficult for the portal vein to push the blood into the liver. So the blood accumulates in the portal vein, and because there is accumulation of blood in the portal vein, there is accumulation of blood in its tributaries. Okay, the splenic vein and superior mesenteric vein. In the spleen, when the blood accumulates within the splenic vein, the blood exits with the difficulty from the spleen. So the spleen will start accumulating blood within it and start enlarging. Okay, and this condition is called as congestive splenomegaly. Congestive splenomegaly. So we can understand that whenever there is cirrhosis, there will be enlargement of the spleen because of congestive splenomegaly. The next thing that happens is these vessels, okay, at these portocaval anastomotic site, these branches from the portal side, they inform the systemic side that, okay, I am not able to push the blood into the portal side, so can I push the blood through you? So it says okay, and they establish a connection between themselves. Now when they establish a connection between themselves, these anastomotic sites, they dilate because now there is a lot of blood flowing in these areas. And when the anastomotic sites, they dilate, the vessels or the veins, they become enlarged, thin-walled, and they become undulated like this. And we call this as varicosities. Like varicose veins that we see in the clinical side in people's legs. So same thing happens, but at 3 different sites. So when this happens in the abdominal wall, okay, it gives an appearance called Medusa head appearance. So Medusa was a mythological character who had snakes on her head instead of hair. So when these varicosities are seen around the umbilicus, we call it as Medusa head appearance. In the rectum, these varicosities will give rise to hemorrhoids, which can lead to bleeding. But most importantly, in the lower end of the esophagus, when there are varicosities, okay, they can rupture. They are very, very prone to rupture because they become thin-walled. And once they rupture, it is very difficult for the body to control the hemorrhage that will happen. Okay, actually, many of the patients, once they start hemorrhaging, they tend to die. So a lot of people of cirrhosis die not because of liver cell failure, but because of hemorrhage from the varicosities at the lower end of the esophagus. Okay, and unless the patient is brought to the hospital and some surgical intervention is performed like banding or sclerotherapy, it is very unlikely that a patient of hemorrhaging from the varicosities will survive. So that is the importance. So in this slide, what we have seen is, we have understood why congestive splenomegaly happens in cirrhosis. We have understood what happens when there is a dilation of the veins at the portocaval anastomotic sites. The patient can die because of hemorrhage. He can develop the Medusa head appearance on the abdominal wall, and he may develop hemorrhoids in the rectum. So this is the second thing that you need to know about portal circulation or the liver. The third thing you need to know about before we proceed to the topic proper of cirrhosis is what happens when the liver function is reduced. Now the liver function in cirrhosis reduces because of 2 things. First thing, we have already seen, the connection between the hepatocyte and the sinusoid is lost, so exchange doesn't take place, which means the blood is almost has no benefit of having passed through the liver. That's first thing. Second thing is, because of chronic inflammation and because the exchange of oxygen is hampered, the hepatocytes, they start getting damaged and they start dying. Okay, so both of these reasons contribute to the decrease in the liver functions. So once we understand the liver functions, okay, what are the different functions, we will be able to understand what happens when there is decrease in the liver function, which will help you understand the clinical features of the cirrhosis. Okay, so when the liver function is reduced, the carbohydrate metabolism is hampered. So there is problem in gluconeogenesis and glycogenolysis, which can make the patient hypoglycemic. Okay, decrease in the protein metabolism abnormality will cause wasting of the muscles of the body. Okay, and lipid metabolism can lead to hypercholesterolemia and many other problems with the lipid metabolism. When the synthetic function is hampered, we already saw that the hepatocyte produces albumin. The albumin goes, so there is reduction in the albumin. When albumin is reduced, what happens? The oncotic pressure will come down of the blood. We know that albumin is very important in maintaining oncotic pressure. So when the oncotic pressure goes down, the patient has a tendency to develop edema because the hydrostatic pressure remains intact. The oncotic pressure has come down. That means the fluid that has exited into the soft tissue, it's not going to come back into the capillaries. Okay, so there is a tendency for edema. Next is detoxification. Okay, so in detoxification, it's very important. We know that liver is required to detoxify a lot of elements, most importantly what is called as ammonia. Okay, ammonia is detoxified into urea. But when there is a decrease in liver function, ammonia will accumulate and it will lead to something called as hepatic encephalopathy. Hormone regulation. Liver is important for metabolizing estrogen. So when estrogen accumulates in the blood, in females it will not cause many manifestations, but in males it can give rise to gynecomastia and testicular atrophy. Liver also is responsible, it is one of the reticuloendothelial system, so it is responsible for filtration of the blood and all the microorganisms get captured here. So when the liver function is reduced, blood filtration is reduced and patient becomes prone to infections. Also, when there is a lot of fibrosis in the liver, we will see why. The exiting of the bile from the liver is hampered. So the bile will pool, or it will pool into the blood, it will go into the blood and it will cause jaundice. And it will also hamper the liver, because of cirrhosis, the storage of vitamin, minerals and glucose is also hampered. Okay, and you can develop manifestations of deficiency of these. And of course, liver also performs immune function. So the patient becomes less immune competent. So if you understand the liver functions, we can understand that in cirrhosis, there might be hypoglycemia, there will be wasting of the muscles, there will be hypercholesterolemia or hypocholesterolemia, there will be hypoalbuminemia, and also liver also secretes coagulation factors. So there is a tendency for bleeding. There is a tendency to develop hepatic encephalopathy because ammonia is not metabolized. There is a tendency to develop testicular atrophy as well as gynecomastia. There is an increased chance of infection. There is jaundice. There is problem because of deficiency of iron, vitamins and glucose, and there is hampered immune function. So you need to understand all these things before we proceed to the topic of cirrhosis proper. Okay, so once you understand this, understanding what happens in cirrhosis and its complication becomes very easy. So thank you for listening, and hopefully I'll see you in part 2 of this video.